Um, so good evening, everyone. Welcome back after a little bit of a hiatus here. We had a really busy summer for a lot of us, and got to be a little bit much to have these scheduled every week. So we apologize for the break. But we're really looking forward to having everyone back on a pretty ongoing basis for the next few months. Tonight we have joining us again Dave Brown. Dave's a primary care paramedic and emergency medical dispatcher with BC Ambulance, and is also one of our divisional members here at 176. And I'm going to let Dave introduce. I believe you're doing pre-hospital chest pain. No, I forgot
You're
what
about as confident in that topic as I am. So.
I'm going to let Dave introduce his topic because we haven't actually talked about it for about a week since we talked about him doing this. I'm going to let him introduce everything. Just as a reminder for everyone, we are hoping to continue these training sessions on a weekly basis moving forward, and we look forward to seeing everyone for those as well. And with that, pardon me, I'm going to ask everyone. We're going to ask everyone, please keep your video off and your audio muted throughout the presentation tonight. The reason for that is if you turn your video on, we then interject videos of yourselves doing whatever you're doing into the recording of this, then gets published onto YouTube later. And as much as we love to see your faces, it can be a bit of a distraction, especially in the recorded sessions. And same thing, if you have questions, please type your questions into the Zoom group chat. What'll happen is I'll be curating questions throughout the evening. We're probably going to wait until the end, I think, for
There's a couple good pauses baked in where we can get some section-specific questions in there.
Sure, yeah, but what we're trying to avoid is we're trying to avoid people just jumping in with questions in the middle of what Dave's talking about. So please throw them in the Zoom group chat, and Dave, you can cue us up when you want to know what people have been asking, and whatever else gets saved to the end gets saved to the end. And with that,
Awesome.
Here's Dave.
Perfect. Thanks, Nick. Thanks everybody for coming out. It's good to be back at these. The one other thing I'll add to Nick's introduction is we're hoping that people can avoid trying to answer other people's questions in the chat. We had some issues earlier on with some of these questions where people were giving some less than accurate or off-topic answers, and it gets quite distracting for a lot of other people seeing the chat box go by that way. So tonight we're going to be talking about pre-hospital assessment and management of chest pain. And unfortunately, as much as it's a great broad topic, really what we're going to be talking a lot about are just very common causes of chest pain and some of those there. We'll talk a little bit about how to differentiate between those and a little bit of everything else, and we'll go through a proper title slide. The common disclaimers here, nothing in here is updated to reflect COVID practice guidelines. So if you're in part of a division that's still doing duties through COVID-19, there are updated clinical guidelines around extra protection from COVID. It doesn't cover that. There's a few things that I'm going to mention in here that aren't reflected within the scope of the MFR. Just because you were here and David said, oh yeah, this is how you take an ECG, does not mean you're licensed to take an ECG. So tonight we're going to start with a very quick anatomy of the circulatory system through the body. We're going to talk about some common causes of chest pain. We're going to talk about how we're assessing chest pain and how we're going to approach assessment of patients that are presenting with chest pain. We're going to talk a little bit about pre-hospital treatment of chest pain, and then we're going to talk very briefly about in-hospital treatment of chest pain as well. So we're going to start off with a little bit of anatomy. None of this is critically important to your understanding tonight, and it's definitely not critically important at the MFR level, but I really think having a basic understanding of what's actually happening in the underlying systems makes a big difference, and you're able to understand and start thinking clinically instead of just following protocols. So in the circulatory system, the very basic version is blood is oxygenated in the lungs. It gets pumped from the lungs into the heart. The heart pumps it back out into the body through all the arteries. And then the veins bring the blood back to the heart to be oxygenated and circulated again. So as we get to the heart there, deoxygenated blood, so blood that's already been through the body and has taken all the oxygen and nutrients out, it's going to come into the right side of the heart. It's going to get pumped from the right side of the heart into the lungs. from the lungs back into the left side of the heart, and then the left side of the heart pumping back out into the body. In the heart there, again, fairly straightforward. And none of this is really what you need to understand, but it's interesting information. The blood, just showing a little bit of a diagram on how blood moves through the heart. And this really isn't anything you need to understand here. But one critical part that we will show you here is the blood's heart supply. And so the outside of the heart has a number of arteries that provide the blood flow to the actual muscle tissue of the heart. Those come off of the aorta, and they're going to be a critical part of what keeps the heart going and keeps the blood supply flowing to the heart. So we're going to start talking about some of our causes of chest pain here. So this is a quick list, but it's by no means exhaustive. And then of the list here, these are the ones we're going to talk about tonight that I've highlighted here. Those are going to be our most serious and most common ones. There are a few other things like myo and endocarditis that are cardiac infections. There are some things also like GERD, gastric reflux, heartburn, and anxiety, some other heart conditions that can present with chest pain but aren't necessarily cardiac problems. And we're going to talk about this more later, but the very short version of this presentation is that there's no actual way for us as MFRs at events to be able to really safely determine the difference between a problem with the heart and a problem being something else like just heartburn, anxiety. And so I don't even really want to go into too much detail about some of these other conditions, just because I'm concerned that's going to start making people include those more actively in their differential diagnoses than we want. So our first one we're going to start talking about here is a myocardial infarction, or an MI. And it's just a really fun word to say right off the bat. So it's caused by blockages in the coronary arteries. So in the coronary arteries that provide blood flow to the heart, they're going to get a blockage coming up from the body. It's typically a small piece of plaque or fat that breaks off from inside the lining of some of the coronary arteries, and then eventually reaches down and blocks the blood flow. And because that blood flow is blocked to the heart muscles or the myocardium, it means that it's not getting any oxygen or any of the things it needs to survive. So eventually it's going to start to die. So the classic symptoms that we're going to see for an MI, an MI is the medical term for what's commonly considered a heart attack. That's where you're going to start to see the chest tightness, the pressure, the burning right in the center of the chest or on the left side of the chest. A lot of the time you'll have people complaining of pain that goes up into their jaw, up into their arm, up into their back. Typically, you'll see an increase in heart rate as the rest of the heart starts to try and compensate for the part that's injured. And then you will see either hypotension, hypertension, or none of the above, depending on where in the heart the blockage is. So it's a really effective way of determining the difference there. A lot of the time too, because they're not getting enough blood flow through the body, you'll start to see dizziness as their brain just isn't getting enough blood there. And diaphoresis, so like an extreme level of sweating, is also quite common associated with this. Now, while those are the classic symptoms of the MI, and that's what you'll see in whatever TV shows you're watching these days, it's just that like classic burning, crushing pain right there. They're actually not the most common symptoms, and particularly in women. Women are actually more likely to have what's considered an atypical or abnormal presentation than they are to present with that crushing left-sided chest pain. So you will see women whose only complaint can be any of these. So I've seen it before. A woman, all she was complaining about was just indigestion. She just had a really upset stomach and she was having a monster heart attack. The same similarly, women presenting only with shortness of breath, only with a sudden onset of unexplained severe weakness. And a lot of the time they'll have some of that associated pain. So the classic presentation involves chest pain radiating up to the jaw. Sometimes you'll have women who just only complaining of pain into that jaw. And this really wasn't something that we understood for quite a while. And so for a long, long time, women had a significantly higher mortality rate for myocardial infarctions and heart attacks than men did. And even in 2016, women had, I believe, within a year, they had a 26% mortality rate within a year versus 19% in men in the United States. And while that number is consistently becoming closer, women do still have a much higher likelihood of dying from a heart attack than men, largely because they tend to present with a lot of these symptoms that don't that aren't classic, and so it's not necessarily recognized as a heart attack or as being as serious of a cause. So moving on from MIs, we do also have angina. So angina is the same, ischemic chest pain, so chest pain caused by a lack of oxygen supply to the muscles. But in this case, instead of being caused by a blockage, it's just caused by a narrowing of the artery. So we can see in this picture here on the far left, there's a very normal artery, and so blood can flow through there clearly. But as plaque starts to build up in the coronary arteries there, it restricts the blood flow. It presents very similarly to a myocardial or infarction or just a regular heart attack. And we differentiate it in a couple of different ways that we'll talk about on our next slide here. So it is associated a lot of the time with that classic like chest pain, tightness, pain radiating to the jaw, the shoulder, the arms. Now, the big difference that we'll see here is that stable angina typically presents as I felt fine, then I started shoveling snow on my walk. I started to get some chest pain. I stopped shoveling snow, and now I feel better. So that's where you're seeing is the demand for blood to the heart is totally fine until they start working harder. The heart's working harder, starts needing more blood flow, but then it's suddenly restricted by the narrowed coronary arteries. And while it's always worth investigating and following up on, the really concerning form of angina is the unstable angina. So it's going to be pain that comes on either at rest or minimal exertion. So someone who's just sitting in a chair and starts to get that chest pain, that's much more concerning than someone who maybe had the chest pains coming on when they were shoveling snow, especially if someone has an existing diagnosis of chest pain. The other one too is if their angina pain starts to get worse. Typically it's very consistent from episode to episode, but if they're saying the last 3 episodes of angina they've had have all been getting worse and worse and worse, that's also a pretty significant symptom and suggests unstable angina. But similarly, all the symptoms, because the mechanism is almost the same, it's very difficult to differentiate angina from a heart attack. And again, it's really not something we can do effectively in the field. A lot of patients that have angina will have their own nitroglycerin spray. So it's just a small spray bottle that they spray underneath their tongue. And that essentially works as a vasodilator. So because the coronary arteries are blocked off, they need to be relaxed open a little bit to allow blood flow through there. That's obviously not a medication that's going to be within the scope of an MFR, but a lot of these patients may ask you if it's okay for them to take their own nitro. And that's a bit of a sticky situation for us, but you can always essentially just make sure they're following their guidelines from the doctor. We can't be the ones spraying it under their tongue for them, but if they choose to take their own, that's certainly not a bad idea. So moving on from angina, one of our next ones, and this is actually much more common than a lot of people think, but pulmonary embolisms. So this is going to be pulmonary or the lungs, and an embolism is just the same as what you'll get for something like an MI, typically a piece of detritus floating through the body. And as the blood vessels become narrower and narrower, eventually it will just lodge and stick there. So in this case, it's going to be stuck in the arteries that provide either blood flow to the lungs or some of the arteries that come into and out of the lungs, providing blood flow for oxygenation. Because again, some of these arteries are what provide blood flow to the lungs, you can get an infarction or tissue death into the chunk of the lung that's being damaged there. So you can have some of the lung muscle and lung tissues start to necrose and die there. And it's actually a remarkably common cause of unexplained sudden deaths. So the vast majority, I believe over 90% of pulmonary embolisms are caused by what's called a deep vein thrombosis, traveling from the legs. So there's a lot of risk factors there. So issues like long periods of stagnation where blood flow has been reduced through the legs, estrogen-based birth control medications, smoking, recent surgeries, a lot of things like that make it much more likely that people will develop these small clots in the legs that will eventually break free and travel up into the lungs. Very rarely, you can also see air and fat embolisms, which are essentially either a large bubble of air, typically from some medical procedure, and breaking free, or fat that's made it into the bloodstream and then gets stuck in the lungs. In pregnant women, amniotic fluid can sometimes make it through the body and into the blood flow, which is a very serious concern, but quite rare. So our symptoms of pulmonary embolism, I'm going to be, first off, because it's affecting the lungs so directly, a key one is going to be that sudden onset of dyspnea and shortness of breath. They're going to be tachycardic, so their heart rate's going to be increasing. And because the heart's going to have to work harder to try and move blood through the lungs, it means that the heart's going to be going faster to try and move more blood. It can be quite a common cause of hemoptysis, which is another very fun word to say, even though it's a terrible thing. But someone will actually start coughing up blood there. A lot of the time, they'll have a sharp pain directly in the area there. And that pain will be worsened when they try to take a breath or when they're moving their chest. And again, because it is something that affects the blood flow through the lungs, you can start to see cyanosis, or like see blue around the lips, blue in the fingertips. I elected not to include them in this slideshow, but there are some really fascinating pictures on the internet, if you do choose to Google them, of emboli that have been removed from the lungs, typically in somebody who's died at a post-op setting. But these just absolutely massive clots that can travel deep into the lungs and deep back into the body. It's quite interesting if that's something you're interested in, and I'd suggest going to look at it if you're okay with looking at kind of gross pictures, but medically very interesting. Moving on, we're almost through some of these causes there, and this is the less exciting part. So the spontaneous coronary artery dissection. So it's relatively uncommon. This is not something that I would keep high on my differential list, but it sort of leads into our next cause, which is also worth considering. So that's where the coronary arteries that are providing the blood flow to the heart muscle actually start to separate. So a lot of the time you'll have a small tear on the inner layer of the artery. It'll lift up, blood will flow underneath there and start to pull it apart. And because, again, it's causing damage to that blood vessel, it means there's less ability for the heart to get oxygen. You'll start to see some of that infarction and necrosis into the heart. Interestingly, it occurs almost 90% of the time in women, typically in younger women, approximately 30 to 45. So while a lot of the time the younger women, and even into their 20s, that's an age group that a lot of people will immediately assume it's not a heart problem and maybe something more like anxiety. There are still quite a few causes of genuine cardiac problems that are associated with women of that age. So it's definitely could still be a real cardiac problem and always worth keeping in there. So the symptom list is almost identical to the rest of some of these causes we've discussed, but you'll start to see that ischemic chest pain. So again, that classic aching, burning, crushing pain. You'll see an increase in heart rate. A lot of the time you'll see some difficulty breathing. You'll start to see diaphoresis, so becoming extremely sweaty. And our last cause we're going to talk about today is the spiciest one. So the aortic dissection. So the aorta is essentially a massive fire hose of a blood vessel, or of an artery, that travels off the top of the heart. So you have the ascending aorta comes off the heart. The aortic arch crosses over the descending thoracic aorta that crosses through the body, and then travels down into your stomach. If you're particularly bored and laying in bed one day, a lot of the time, if you sort of push moderately hard into your stomach and feel around a little bit, you can actually feel your heart rate through the aorta there. So typically people will talk about either the aortic arch aneurysms, a dissecting your thoracic aortic aneurysm or dissection, and an abdominal aortic aneurysm or dissection. So an aortic aneurysm is essentially when a small part of the aorta splits off. And so similarly, you'll have that small tear inside the wall and some blood will start flowing through there. And because the aorta travels so much blood through there, it's under quite high pressure. And so that increased split puts huge pressure on there. And eventually it can just tear open, leading to almost all of the blood that's being pumped out of the heart just being pumped straight into the body. It can be fatal within 30 to 40 seconds when the aorta actually dissects like that. I've transported patients that were coming from one hospital to another directly for surgery, and we've seen what is believed to be the aorta essentially dissecting in front of everybody, where the patient just suddenly just absolutely just disintegrates and crashes hard there. These can be extremely serious. Untreated, 50% of aortic dissections and aneurysms are fatal within the first 24 hours when unrecognized. Now, the good thing is these are associated with some fairly specific symptoms, and it really is a tearing or ripping pain. And I've had a few patients experience this, and every one of them described as just someone was tearing apart there. It can present in their chest, it can present in their back, it can present in their abdomen. A lot of the time you'll see nausea and vomiting, and then hypotension is also quite commonly associated with a very low blood pressure. And that's because a lot of the time, even if you're having these dissections, it starts to impede blood flow through the aorta. And so the body's just not able to pump blood through quite as effectively. And then I outright lied because we do have one more cause here. It's gonna be the pneumothorax, or a collapsed lung. And so what's happening here is you have pneumo, or air, and entering the thorax. So it's most commonly associated with traumatic causes. So basically somebody creating a hole into the chest. So either a stabbing, a gunshot wound, falling onto a piece of rebar, or any of that sort of thing. But they can also occur spontaneously without any traumatic cause there. And so that's always worth considering, especially as one of your differential diagnoses. So the highest risk for a spontaneous pneumothorax is going to be in taller, thin, younger men. And it's also going to be a very high risk for people who have an existing lung disease. So if you have somebody who's a little more elderly, has a history of COPD, asthma, has been smoking their entire life, their lung tissue is very fragile. And so it's quite easy for that lung tissue to break in a small place and start releasing air into the chest cavity. And while it's a problem, obviously, that one of the lungs isn't functioning, that in itself doesn't necessarily create an immediate life-threatening condition. But what happens is as the air starts to enter the chest, it starts putting pressure onto the other lung and pressure onto the whole lung structures, which is called a tension pneumothorax, and that immediately can become fatal there. So what we'll see for symptoms of a pneumothorax, when you see difficulty breathing because one of their lungs isn't working, typically a very sharp chest pain, again, typically located right where the actual injury site is. We will see diminished lung sound. So if you're auscultating with your stethoscope listening there, on the actual site of the pneumothorax, you will hear typically just nothing, or some very faint or some pleural rub. But that said, that's a relatively unspecific test for a pneumothorax. I think it needs to be in the 20 to 30% collapse range, largely before you'll actually hear some of these diminished lung sounds. So just because you can hear air everywhere you listen, and you can hear air right over the site that someone's complaining of pain, doesn't necessarily mean that they're not having a pneumothorax. Again, as we're starting to see a difficulty in blood flow through the lungs and the heart will start to speed up, so it'll become tachycardic. And again, in these very severe patients that are moving towards a pneumothorax, you'll start to see tracheal deviation. So your trachea runs down the front of your throat and splits into your lungs. But as your lungs are being pushed over, it'll actually start to shift sideways. And that is a relatively uncommon, very severe sign of a tension pneumothorax. And you will also start to see, as one lung becomes so badly damaged and collapsed, you'll start to see an unequal chest expansion. So when somebody takes a breath in, the side that still has a functional lung will expand much more than the other side there. So that's all I've got for some of these common causes, signs, and symptoms there. I don't know if we have any questions, Nick. Nicholas?
Hey, sorry, I was trying to find my unmute button.
There we go.
Sorry, I've got things running on two different displays here, so I was just trying to figure out where my mouse was. We just had a couple of quick questions from, not even questions, just comments. Carly McIntyre just said, thank you for including a difference in presentation in women and talking about the difference in presentation between male and female patients. That is something I think has historically been maybe downplayed, though it's certainly been emphasized in the last 5-10 years or so. And
and sorry, just jumping in there for half a sec, Nick, that's actually something that's been really noted, is the mortality rate for women of heart attacks is significantly decreased relative to the mortality rate for heart attacks in men. And the American Heart Association largely associates that with much better education among healthcare providers and the community of some of these uncommon atypical presentations in women.
Yeah, no, I'm aware even that I believe Heart and Stroke here in Canada has been pushing for some funding to be able to do more to research some of the differences in like long-term care as well. But and then Mike Hoskinson just added that the birth control pill is probably the most common. I believe he's talking hormonal birth control. Is probably the most common cause of PEs in young women, which I think is oral contraception along with smoking, I think, are two, and a higher body mass index. I don't think even obesity necessarily, but those three all together are sort of the trifecta that make people particularly susceptible to PEs. That's all we've got so far for group interactions. So I'm going to turn my video off here.
Anybody have any other questions there just before we move on? All right, great. So we're moving into our assessment of a chest pain patient, and this is maybe a little bit nebulous. And so I'm going to include a quote I like. I've quoted myself in this presentation, but the very short version is there's no way for us at the MFR level to safely differentiate between cardiac and non-cardiac chest pain. So there's no point where as an MFR, we should be saying, no, I don't think this is your heart, you're fine, go home. For us, any patient really presenting with chest pain needs to be referred to a higher level of care. But that said, we can look at our assessment to try and guide us towards some of our possible differentials there. So our primary assessment is really just like normal. So the airway, make sure they have a patent airway, make sure there's nothing else going on there. If their chest pain is caused by the fact that they have a grape lodged in their throat, solve that first. Breathing, a lot of these cardiac issues quickly also evolve into respiratory issues. So take a really good look and make sure they are breathing patently, make sure they're breathing effectively, make sure they're not needing an immediate breathing support such as oxygen or potentially even assisted ventilation. For circulation, your primary assessment isn't your time to sit there, watch out, time your full 20 seconds or 50 or however long you choose to take a pulse for, but you should be still taking a radial pulse and just note the quality of it. So does it feel really weak and fast at the wrist? Is it extremely slow at 30 beats per minute? Is it extremely strong? What are you feeling there? Just take a quick note of that. And the other thing really start looking for there is if somebody comes up to you and they're saying they have chest pain and you just look at them and they're gray, they're sweaty, they look like absolute garbage, that's a time to start considering an early activation of higher care. So most of the time we do talk about when in your patient assessment you want to be calling an ambulance, and that's definitely a time to consider starting an ambulance and making that 911 call very early in your patient interaction with your patient. So of your physical assessment, most of the time there's not actually that much we're going to gain in detail when we're differentiating in a physical assessment. You should still be doing a proper secondary survey there, but most of the information we're going to gain there doesn't make a huge difference. One of the key things that will is making sure you're taking the time to get really good, accurate, detailed vital signs. There's a lot of patients where it's totally fine to make sure that your blood pressure is within a ballpark there. Their breaths are probably 16. But in this case, a lot of the time when these patients are going to be going to higher levels of care, having that detailed history so they can start to see the trends of somebody's vital signs can make a huge difference. So if in the tent they're presenting with a perfect normal 120 on 80, their heart rate's 65, their respirations are 20, but they're complaining of a little bit of chest pain. And then by the time they get to the hospital or the paramedics show up, all of a sudden their blood pressure is 60 over 40, their heart rate's 110, and they're starting to look a little gray and blue around the lips. That paints a very clear picture that somebody is becoming increasingly sick very quickly. And so having those early vitals helps paint the picture, especially as the patient travels through the healthcare continuum. It is worth making sure you take the time to listen to the lungs pretty carefully. It can tell you a lot about it. It can help differentiate maybe sometimes between an infectious shortness of breath if you're going to be hearing the very thick, goopy sounds. Sometimes respiratory conditions like asthma and COPD can cause chest pain associated with lung problems. And so when you'll start to hear some of those wheezes, those rubs, might suggest to you that it's more of a respiratory issue that's causing the chest pain versus a cardiac issue that's causing some shortness of breath. And again, it seems silly, but it's always worth including here. make sure there isn't some traumatic injury to the chest. So when somebody walks up to you and says, my chest really hurts, and you're immediately thinking, all right, this is it. This is my unstable angina. And no, it turns out he's just been hit in the chest with a baseball bat. It's not necessarily something you have to do physically. And I would be cautious, especially in women, about doing like any kind of revealing physical exam, especially as providers where we're working in more public spaces, unless there's something really specific you expect to find there. So if you're looking for signs of anaphylaxis, so you're trying to find hives, rash, urticaria, anything like that, or you're looking for details of some kind of traumatic injury. But otherwise, a full physical exam isn't necessarily going to be particularly helpful there. So now getting into our history, this is really where taking the time to get a detailed history is going to set you ahead. So when we're talking about their chief complaint, one of the key ones is what were they doing when the pain started? Like we were talking about before, with stable or unstable angina, like somebody sitting with a sudden onset of chest pain is much more concerning maybe than somebody who was walking up a steep hill and then started to have the chest pain come on. And even with an MI, a lot of the time it will start to provide some information. Chest pain starting at rest is very different than exertional chest pain there. The timing of the pain, so if they've had this pain for 3 days, and it's not saying that it's not cardiac, but it's maybe moving away from likelihood of it being an immediate critical likelihood of decompensating. And this is where we want to get a really, really good description of the pain. So whatever acronym you like to use, low TARP, OPQRST, I use low TARP. So just as an example here, when you're talking about the location, instead of saying the pain is in their chest, yes, you're right, but that's where getting a detailed picture is. So a lot of the time, a great way to do it is use one finger and show me where the pain is the worst, and they'll give you a direct spot. So instead of saying it's across this whole left side, it sort of gives them the most detailed spot, and that's going to help paint part of your picture. So the onset, it's similar to what, that first question, what were you doing? What happened? When did it start? The type, so if we're talking about crushing, stabbing, squeezing, burning, the timing, so is that pain always there? Does it come and go? What's happening there? Treatment, have they tried to do anything that makes it better? Radiation is another huge association with this and something that's important to know. So are they getting that pain radiating into their jaw, into their shoulder, into their arm? And then provocation, so is there anything that makes it worse? After, if doing twists makes the pain worse, if breathing in makes the pain worse. Again, that's not ruling out cardiac causes, but it maybe moves them a little bit lower down on your differential list there. So having that really good description of the pain and be able to, when you're passing off to a higher level of care as part of your handover, be able to paint a really clear clinical picture of exactly what's happening, and paint a clear picture of what type of pain that person's having. The different stories you provide will, a lot of the time, provide a really clear window for higher levels of care, what kind of chest pain you're giving over to them. So along those lines, one of the things that we also want to look into their past medical history. So do they have cardiac or respiratory history? Someone that's got a history of 4 heart attacks, a couple stents, 2 strokes, and COPD, that's going to be much more concerning for something like a cardiac event versus someone who's otherwise healthy, was checked last week at their doctor and doing well. One of the other things we know is that a history of death or cardiac injury, so if their dad had a heart attack at the age of 35, that's very concerning that they're more likely to be experiencing a cardiac event at a younger age like this. Similarly, a really high yield question sometimes can be, have you ever had this pain before? And if they say, oh yes, this feels just like the last time I had a heart attack, that's a very concerning finding, and that's something you should absolutely take seriously. And I think nearly every one of those that I've had has turned out to be the exact same thing. So again, just because they don't recognize the pain or they don't, it doesn't mean it's not cardiac or not this. But if this pain is recognizable and similar, a lot of the time, that's a very clear warning sign. And then for medications that treat the pain, so especially people with angina, people who have had it for a long time, they have their nitro spray. So they've been told if they start to get the chest pain in, you just lift up your tongue, spray it under your tongue, and a lot of the time it'll go away. So it's just worth following up there. Some other risk factors just to be aware of for somebody that's having a cardiac event. So patients that have a history of diabetes, uh, diabetes is a bad disease in general. It does a bunch of things. It makes you less able to regulate your cholesterol. It makes you less able to maintain a healthy weight. And it also damages nerve endings. And so it leads people to be even less likely to present with the classic cardiac symptoms there. So someone that's diabetic and is just having maybe some jaw ache, maybe just some like funny feeling around their chest is someone you should still be very concerned for having a cardiac event. Hypertension, so a history of high blood pressure, makes them significantly more likely to have a lot of these issues. Smoking is a huge risk factor for early cardiac events. High cholesterol, on the same lines, the cholesterol builds up throughout all the vascular system, along the coronary arteries, along the aorta, and just makes them more fragile. And the cholesterol is also more likely to break off the more that builds up there and forms some of these emboli. And like we just talked about, a family history of heart disease is also a huge risk factor. So we're going to move on to treatment here in a second, but if anybody has questions they want to talk about first, now is the time.
We haven't had any questions in the time you've been talking, Dave.
Great.
Hoskinson just posted he enjoys the equipment in the background of the picture you displayed.
I also quite enjoy it. So I found this picture by Googling doctor doing patient assessment. And it's a funny picture because the more you look at it, the weirder it gets. And I could find almost no information about it. But anyways, I also enjoy that picture. Thanks, Mike. So when we're talking about treatment of chest pain, there's not a whole lot we can actually be doing here. We're going to move a patient to a position of comfort, so either sitting or laying down. If somebody is experiencing any form of respiratory distress, they should be sitting up and not laying down. But if someone's not having trouble breathing and their main problem is chest pain, whatever's really is going to be most comfortable for them. If somebody's oxygen saturations are below 95%, we should be supplementing with oxygen. There's a whole thing that I'm not going to dig too deeply into, but providing supplemental oxygen to patients that are having cardiac events when it's not necessarily needed. So for a long time, any patient that was having chest pain, even if they were satting 98%, they might get still a non-rebreather mask turned up to 11, just to make sure they got all the oxygen in there. And there is some growing evidence that causes actual harm. That said, you are never going to be wrong to be following the St. John Ambulance treatment guidelines, which I believe do reflect high flow oxygen for chest pain patients. Maybe Nick, you can chime in for that for a second.
Everything you said is completely accurate, and as is the case with first aid organizations, sometimes the actual boots on the ground practice takes a couple of years to follow the latest evidence-based medicine, just because there's a whole process that has to be gone through in terms of vetting through ILCOR, the international consortium that dictates resuscitation guidelines, and then things have to be adopted by St. John, and then things have to be adopted into the local, and so on and so forth. It does take time for changes like that to work their way down to the ground. As a general rule, do what you've been trained to do. I think the likelihood of causing massive or catastrophic harm by administering oxygen, from what I understand about the science, is quite low. When we talk about like administering that oxygen to people having cardiac events being harmful, we're talking, one patient in 50 or one patient in 100. I don't know what the actual numbers are, but it's like that. Where some people might receive more benefit from not having that 15 liters, and maybe a bit lower.
Yeah, and I think you can also just look at, sorry, go ahead, Dick.
You can't differentiate that in the field with the tools we have, so do what your training is. And if your training says 15 liters a minute of high flow oxygen, give them 15 liters a minute of high flow oxygen. At the end of the day, it's that straightforward. And we do have a couple more questions in the group chat here if you wanted to respond to that.
Yeah. So what Mike was saying, and I think this is, really the takeaway we can generate here, and it's not don't give oxygen to patients, but it's an opportunity to use your thinking cap a little bit and try to understand what this patient actually needs. and maybe consider moving towards something like a nasal cannula instead of just immediately going right to your 15 liter per minute non-rebreather mask there. So I almost always would start one of these patients on a nasal cannula and see what happens to their saturations there. But again, this is in patients that are presenting without an acute shortness of breath. If someone's standing in front of you and is breathing at 60 breaths per minute, their saturations in the toilet, they look like absolute garbage, absolutely, that's a patient you need to be aggressively supplementing oxygen on. We're really talking about these patients that are just sitting there with their real problem being just that pain in their chest. From what Carly said, I would still be, Carly asked, if you've got a patient that's got a history of COP and their normal saturations are quite low, would you still provide supplemental oxygen? And the answer is yes. The main issue that we're seeing in the majority of these ones that are issues with the heart are caused by a lack of oxygenated blood to the heart. And so someone might be able to quite effectively normally exist with their saturations being in the 90s, the low 90s, and it's quite common. But in this case, some supplemental oxygen that's going to maximize the blood flow, the flow of oxygenated blood to their heart is going to could make a big difference in helping the heart tissue last longer before we get to a higher level of care that can do something about that. Yeah, with what Mike was saying, I won't dig too deep into the physiology of what's going on with providing lower amounts of oxygen there, because I think it's not particularly relevant to us today. But it is interesting, and if it's something people want to talk about, send me an email, and I'm happy to have a discussion about it that way. Any other questions about that before we're moving on here? So again, this is something we should be, our treatment in this case is transport. And as much as I kind of hate the idea of diesel therapy, these are patients that need to be assessed in an emergency department with the capability to actually find some answers there. So in Victoria, a lot of major centers that have advanced life support paramedics, they'll be dispatched to these chest pain calls. They can do a heart tracing on the scene to get an idea of what's going on. But really the definitive answers are going to be labs that can start showing what's actually happening in the heart, as well as potentially angiograms that we'll talk about a little bit later there. So in this case, part of your treatment plan should be making sure you're calling 911 fairly early in this process once it's clear this patient is unwell. And then as well, we're going to talk a little bit about aspirin here, and it's a consideration for your treatments here. So acetylsalicylic acid, or ASA, the generic of aspirin created by Bayer. So it's a platelet aggregation inhibitor, which is a very fancy word. And so what's happening is when you get these emboli, so you might get a blockage into the heart, for example, into one of the coronary arteries. You have your small little thing that's floating through and manages to get wedged into an artery. And maybe there's a little bit of blood flow around on either side, but because it's there, what'll start to happen is other parts of the bloodstream, so some white blood cells, pardon me, other ones, they'll start to form platelets in the blood that start attaching onto that embolus. And so it'll start growing bigger and bigger, potentially expanding to block that full artery. And in severe long-term cases can actually start backing up into other arteries to restrict blood flow there. And so what this does is essentially makes all of these other, what the aspirin does is it makes a lot of these other parts of the blood flow very smooth, and essentially lubricates it a little bit. So they're much less likely to join into that emboli. So it just slows the speed at which it expands there. It is, generally speaking, a very safe, very effective medication. I think it's one of the highest yields if it's administered within 15 minutes of onset of the chest pain. It's got something like a 30 to 40% reduction in mortality. It's huge. Which is why you're seeing so many public service ads and campaigns about there around folks at risk of heart disease, making sure they have some aspirin with them at all times. Because it stops the body from being able to form clots quite as effectively, patients that have issues with bleeding, so someone that's actively got a gastrointestinal bleed, some internal bleeding, anything like that, or a bleeding disorder, at the MFR level, we're not going to provide those individuals aspirin, and almost all of them have been told by their doctor not to take aspirin in these situations. And similarly, If somebody's allergic to a medication, please don't give them that medication. So if somebody's allergic to aspirin, if they're allergic to NSAIDs, which are non-steroidal anti-inflammatory drugs, so if they're also allergic to Advil or Tylenol, they're highly likely to have an allergy to aspirin. So we're going to provide 160 or 162 milligrams, depending on the dosage you have. And then we're going to make sure they chew it. So what happens is when you swallow a medication, it goes into the stomach, has to be broken down by the stomach and then slowly released as it travels through the digestive tract. Whereas when they're chewing the medication and don't wash it down, but if they chew it up, what happens is the mouth and especially under the tongue is extremely vascular and absorbs a lot through there. And so it'll be absorbed into the blood system very quickly there. Higher levels of care, we're going to talk about this very briefly.
Can I jump in really fast there, Dave? Sorry, I'm just going to.
Yeah, absolutely.
Something that, and I just want to make sure that everyone here is really, really crystal clear on this, because I've actually done several calls personally in the last month or so where there's been. Is
this about strokes?
Yeah. So Heart and Stroke, the Heart and Stroke Foundation, HSF Canada, the Heart and Stroke Foundation of Canada, has been done a great job of encouraging people through advertising, through social media campaigns, to take aspirin if you think you're having a heart attack. But because the Heart and Stroke Foundation has been pushing this, a lot of people have been taking aspirin when they think they're having a stroke. And that can actually be a very, very bad thing, especially if you're having a certain type of stroke called a hemorrhagic stroke. So I just want to be crystal clear with everyone that aspirin, if you see an ad from the Heart and Stroke Foundation saying to take aspirin if you're having a heart attack or chest pain, that is specific to the heart part of Heart and Stroke and has nothing to do with the stroke part of things. So please, only for chest pain, only for cardiac events.
Yes, that is an extremely common issue. So thanks for pointing that out, Nick. I really appreciate it. We're about to move on from treatments here. I'll give folks another chance if you have any questions about that you can put into the chat there. While at the MFR level, we always want to make sure we're equipped with the right tools for the job. So we're almost always carrying the 81 milligram chewable aspirins that are designed for that emergency care. You need to take a lot of aspirin. You need to take a lot of aspirin for it to cause serious poisoning and get to the point that it's causing more harm than good. So a lot of the time, it's very common for people to carry aspirin, have aspirin in their homes for migraine. So you can see the bottle that's on the screen here is 325 milligrams. If I was at home and a family member of mine started to have chest pain that seemed like it could be an issue with the heart, I wouldn't hesitate for a second to make them chew one of these, even though it's not the ideal dosage. You need to be getting into about a gram of aspirin before you're starting to see any negative side effects. So just don't be concerned about that outside of the St. John Ambulance context there. The short answer is, sorry, so in the chat, someone was asking there, why are we restricted to 162 per 24 hours? The short answer is that's 162 milligrams is about the therapeutic dose. So anything more than that isn't going to cause any extra benefit that way. I hope that answers your question, makes sense there. So we're almost done. You're almost free of listening to me here. We're going to talk briefly about higher levels of care. So electrocardiograms, heart electrical tracings of the heart. So basically they put a bunch of stickers on there that can pick up the electricity that your heart puts out that causes everything to go. And it can indicate the causes of chest pain. It's not the magic bullet where people just put the stickers on and can immediately know, oh, I know exactly what's wrong with you. But it's a really effective clinical tool there. In BC, it's only performed by advanced care and critical care paramedics. So now in four quick and easy slides, maybe 5, I can't quite remember, I'm going to show you the difference, how to be an advanced care paramedic. This is everything you need to know.
Hey Dave, I'm going to pause for 1 second.
Oh yeah.
I don't know if you saw your work email today. They've actually rolled out the 12-lead ECG trial.
So in a normal ECG, there's the P wave, the QRS, which is the squiggly bit, and the T. And so in this one, we can see a nice small P wave, then there's the QRS, the squiggly bit, and then it goes back to the same level, and then a nice rounded T wave. And there's 3 of them, they all look the same, and they're all in the same distance apart, right? Everybody on board with me so far? This is a bad ECG. So we can see the little P wave, we can see the squiggly bit, but then it does something weird into the T wave. This is called a STEMI, an ST elevation myocardial infarction. This is bad. You don't want your ECG to look like this. This is also a bad ECG. This is called VFib. This needs a rapid dose of electricity. This is an extra bad ECG where you can see one kind of piddly P, and then a little bit of a QRS, and then a much too long gap, and then kind of another P, kind of a QRS, no T, and then there's a little bump, and then there's nothing. And that is not good. You don't want your ECG to look like that. That is associated with going to a funeral home. So that's all I have for that. I'll take questions if you have them now, discuss amongst yourselves, whatever you want to talk about there. Or don't. While people are typing their questions here, just in case anybody is new. So we're back to doing these weekly online lecture series. For anyone who doesn't know, this is going to be based out of our St. John Ambulance Division 176, located in beautiful Victoria, British Columbia, where it's about to rain for 1 week straight. We're doing these every week at 7 p.m. Pacific. If somebody in your division forwarded this email to you and you want to get directly onto the list there, you can send Anna, our divisional superintendent, an email, and she'll add you onto the direct email list. So you'll get the invitations yourself instead of being reliant on somebody else sending them to you. And then we also have social media channels. We're a little quiet right now because we're not doing anything because of COVID, but especially as we start to get back into potentially next summer, it's a really great way to see what we're up to in the division, both for events and training, and start to share ideas back and forth that way. And Mike, I really appreciate your comment, but I know truthfully that's an outright lie, but I'm going to take it anyway and hold it.
Maybe I can just throw in something there. Mike did know that handheld ECG units are pretty cheap. You can get them with 3 leads. I'd like to, you're not incorrect, Mike. I'd like to gently remind everyone that those are wildly outside your MFR scope here at St. John. Please do not purchase those and bring them on duty and think that it's okay to use them. It is not. Having said that, I have personally seen at least one actual MI where an on-site bystander retired pediatrician intensivist, or pediatric intensivist, pardon me, who had got one of these things to monitor his own cardiac health, had actually acquired and saved an ECG of someone having their active MI and had emailed that PDF file to the emergency department before I even arrived on scene to pick up my patient. So they do have some degree of utility, but please don't bring them on St. John duties. That's not the appropriate place.
While we're talking about this is a point that I think comes up a lot in my talks, and I meant to get to it earlier. We cannot, as MFRs, diagnose any of these individual conditions we've talked about today in the field. And as someone who works as a paramedic, if I come up, if you've called 911 and I show up as a paramedic, and you can say, this is Dan, give me a great OPRKST, low TARP, paint a picture for me, fantastic, I'm thrilled, I'm excited. If I come up and you say, hi, my name's Steve, I'm a MFR with St. John Ambulance, this is Dan, and I think he's having a pulmonary embolism. Immediately, I'm going to sort of stop listening. So I understand that while you can inform your clinical picture with everything that we've learned today, we can't make these diagnoses in the field, and these are diagnoses that need significantly higher levels of care and training to be able to make.
It's probably worth noting, or perhaps worth noting, Dave, that the same holds true for PCP and even ACP. I think paramedics delivering handoff at the hospital as well. It's exceptionally rare for me to walk into a hospital and say, I think my patient's having a heart attack. I'll walk into a hospital and say, hi, this is Dave. Dave's a 27-year-old male, has a cardiac history. Today he's having retrosternal chest pain 8 out of 10 radiating to the left arm, and it's worth on exertion. You know, that's not that advice that you've just given to focus
Yeah,
on
absolutely.
not a diagnosis is not something that's unique to the pre-hospital world. That's something that we also carry with us into the department as well. So
yeah, and this is a thing that I have this sort of half-baked presentation in my head about, but there's a real skill to be doing effective clinical handovers and effective communication. But the very short version is, like Nick's saying, painting that picture, presenting the story, giving everybody a clear idea, and being able to take, you know, if you're sitting there for 15, 20 minutes waiting for the ambulance to show up, being able to distill that 15-minute conversation down to a 1-minute handover is a real skill on something we don't practice a lot.
yeah. I see Mike's noted the trick is to use the right buzzword so the paramedic might figure it out. You're absolutely right, Mike.
Yes.
but if you start jumping to conclusions, that doesn't give me any of the information that I need to inform my own decision making. And
Yeah.
you need to get the next upstream level of clinical care also needs to make their own clinically informed decisions, and giving them the information to make their own decisions and help them hopefully come to the same conclusion that you have is pretty important. I see a note from I saw a note up here from Norm at 983. And I hope you don't mind me hijacking this just a little bit, Dave, just to address this. But he says, I have a friend who has most of these problems: high blood pressure, obesity, type 2, presumably type 2 diabetes, family history of heart attack. Is there any BC health agencies which could help him? He lives in Surrey. Norm, I at the risk of sounding too obtuse, his family physician or the nearest walk-in clinic where he might be able to develop an ongoing relationship with his primary care physician are probably the places to deal with all of those. All of those things are long-term chronic health conditions. They're all big ones. They're all important to deal with. But yeah, I think his local family doctor or local walk-in clinic would be the appropriate venue. I also saw a question from Mr. Me. Down the road, can we discuss chest pain management at the MFR level due to weights for EHS? I don't know, Dave, if you want to.
Well, I'll put my other hat on here just because despite this person being a little snarky, it's worth mentioning that if you're going to call for chest pain, most of the time the triage process that happens over the phone really is looking for symptoms and problems. But in somebody that's over the age of 35, the simple presence of chest pain is enough to get at least a BLS response code 3. So it's very unlikely that you're going to be stuck sitting for the multiple hours that you'll sometimes see in the lower mainland for weights. Anything to do with any kind of chest pain, then somebody, as soon as they move into those risk factor ages, is a highly prioritized call. And it's a very low bar to get an advanced life support response added as well. And even in people under that age group, chest pain with any other symptoms of somebody who's having chest pain and also having trouble breathing, somebody who's having chest pain and also having that diaphoretic cold sweat, any of those, even in a 12-year-old, is going to prompt an advanced life support response. But the short answer is it's going to be also just supportive care. So there's not a whole lot we can do other than the standard, which is going to be positioning. So making sure they're in that position of comfort, sitting them up if they're also having trouble breathing, supplemental oxygen if it's appropriate, getting them to take that aspirin relatively early once you've got your vitals, once you've got your contraindications and everything safely done there. And then at that point, make sure you can take the time to get a detailed history, but really you're holding their hand, and if they look particularly unwell, you can put the AED behind the bed where they can't see it, but you have it ready. And beyond that, there's not a whole lot extra else you can do.
Maybe just be a good opportunity now, Dave, to emphasize administration of aspirin is probably
yes.
in terms of looking at hard numbers and the thing that will make the most difference at 30 days, probably the aspirin, which is a little bit counterintuitive because it's 2 tiny little 80 milligram pills and they're just itty bitty little things. when we look at the things that will actually directly and most significantly impact that patient's outcome, it's the aspirin. And that might mean that if you don't have any on hand, if you're out in your personal vehicle for the day, or you're out in your private life for the day and you're helping someone as a bystander, or if you're at a duty and somehow you don't have aspirin in your jump kit, that might mean, you know what, there's a 10-minute delay. Let's try and source this from somewhere else. Hey, does anyone have any aspirin I could have? Would not be an unreasonable thing to do if you find yourself with an abundance of time, you know, you're in a remote location or something like that. But
along those lines too, like outside of the St. John ambulance, like for those of you who either are in my position who have parents who are starting to age, or people who are starting to reach that age themselves, it's also really important to try and make sure you are keeping aspirin available at your home. And it might not be, especially if you're building some of those risk factors, it might not be a bad idea at all to they make some very small bottles, or even individually packaged aspirins, and just have some of those, you know, if you carry a purse or a bag, consistently keeping those with you. And yes, BC Ambulance Dispatch will remind you to give somebody aspirin if they're having chest pain.
Dave, I don't know if you want to for a second. This comes up regularly in terms of dispatch, but the 320 versus 160. Do you want to talk about that really quickly?
Yeah, that's a good point. So St. John Ambulance and most other Canadian agencies recommend a dosage of 160 milligrams. The triage tool that we use in British Columbia over the phone is an American-based tool, and it's a tool designed to be easily accessible for the lowest common denominator. So they suggest a dose of 325 milligrams of aspirin no matter what. So the common adult dosage of aspirin is 320 milligrams. So if you just have like a regular pain relief or headache aspirin, they'll say to just chew one of those. Or if you have the 81 milligram aspirins, they will tell you to provide the patient with 4 of those. It's just a difference in the system. It's designed to be simple and straightforward. It is not wrong. You are not going to poison your patient providing them with that dosage of aspirin. And I would suggest, if you're going to be going through it over the phone, given that you've been told by a medical authority, that is the ambulance dispatch, if you've been told to give somebody 4 81 milligram aspirins, I would go ahead and do that. Not just to talk up myself as a job, but if it's something happens down the road and you have to explain why you were told to give somebody 4 aspirins and only gave them 2, it doesn't look great on you.
That's a great question.
You can absolutely, that's a great question from Nancy. So the chewable aspirins are designed with a flavor. I think we're currently carrying orange in Victoria, and they're designed to be easily chewable. Most other aspirins have what's called an enteric coating on it. So it's essentially a coating that's designed to protect it through parts of the digestive system, so that it's going to be slowly releasing the medication into the stomach and intestines. You absolutely can chew right through that enteric coating. It tastes like hot garbage. I tried it once because I was curious. It tastes absolutely awful, but it is still going to be very effective, still going to get the medication into the bloodstream quickly, and is absolutely doable if you don't have the chewable ones available. Well, I think we'll call it there. If anybody has other questions they have and want to start putting into the chat, you've still got a minute or 2 here. For me, thank you to everybody who's come out tonight. Obviously, it would be no fun at all if I'm presenting just to Nick. I talked to him enough to begin with. These are part of our regular Monday nights that we're getting started up yet. I don't believe we have a topic 100% cemented for next week, so I'm not going to tell you, but I'm sure it's going to be great. So please do come back and join us next week there. Like I said, this is Anna's email here. If you're not on our list already, please send Anna an email. She'll add you to the list. You get 2 emails a week with the reminders. We're not going to send you spam. We're not going to ask you to sign our change.org petition. But we have a lot of fun. So please do keep coming out with us, especially while we're working on some very exciting things for the rest of the fall. We've got some really exciting people lined up for. I'm about the lowest bar that we set for these talks, so we can only go uphill from here. So thank you so much, you guys. I really appreciate you guys coming tonight.
Dave, you're doing yourself a disservice there. I'd like to mention maybe really fast, just in closing here, that as one of the challenges that we've run into as we've gone down these online presentation, gone down the route of doing these online presentations and also posting them onto YouTube, is we've realized that it's a little bit harder for us to get away with repeat topics on a regular basis. So doing a regular in-person training, we might go over chest pain a couple of times in a year, even 3 times or something like that. And it's a little bit harder to justify doing that when you guys can just go and click on the YouTube video and have a look at our previous lectures. I would incidentally really encourage everyone to do that. Go and have a look at the previous online content, because there is some really excellent talks from some really incredibly skilled clinicians available to you now through our YouTube channel. But what we're trying to do, or what we're looking at doing as we move forward, is starting to do maybe some slightly deeper dives into physiology and into understanding the actual, I mean, I don't want to sound too cheesy here, but the actual human animal that we're treating as clinicians, and starting to try and understand what the underlying organ systems are doing a little bit, starting to understand a little bit more about how that physiology impacts what we're seeing in a pre-hospital environment, and trying to deepen our understanding a little bit more. So to that end, we're not necessarily aiming for a particular theme, but we seem to be getting quite a few speakers in the month of October and early November talking about oxygenation. So we can look forward to some talks on pulmonary function. We can look forward to some talks, like full lecture talks on cardiac ischemia, and how the heart muscle uses oxygen, and how the rest of the body uses oxygen, and gets rid of waste products and stuff. So we'll see how this shapes up. We're not quite at a point where we can make formal announcements about this yet, pardon me. But I hope you guys will be joining us for future Mondays as we move forward. Oh, it's a private message. Mike's saying that he's going to put together some talks. Mike, email me, because we would love to have you talk as much as you want to do, my friend. What are you doing next Monday? No, I'm just kidding. But yeah, if I don't.
Nick, sorry, I'm just going to jump in for half a second here. Ken posted a really good point there, asking for reference links. I'll be honest, almost all of this presentation was just written from existing knowledge there. There are some really good articles out there, and honestly, the Wikipedia articles on all of these topics are really good starting points. Like if you're wanting to know more about any of these particular things, a lot of the Google searches are going to will get you some very basic, like taking someone who has no basis in any of these. Whereas the Wikipedia articles, as much as Wikipedia is a bit of a trashed as a source, a really good place to start. And have some really good MFR, maybe a little above levels of information there.
Yeah, absolutely. Ken does raise a really good point, Dave, and it's something that does honestly take a little bit more work to do, but isn't a huge, necessarily a huge burden for us. Is we may be able to start including links to additional resources and references in the YouTube postings. That's something we can look at doing moving forward. It's not something that we've gone hugely out of our way to do until now, but it's a great idea, and we'll see what we can do to add stuff on there. So